Okay, so thank you so much everyone for being here. Welcome to our second event in our Building Brain Awareness to Help Brain Injury webinar series. We are Synapse at the University of Oregon, an organization whose purpose is to serve, support, and advocate for local brain injury survivors. We help organize and foster opportunities and programs for community members as a way to combat social isolation and increase awareness for brain injury community. We do this through peer support groups, social events, educational webinars, and symposium series such as this. We hope to create long-lasting and meaningful connections and encouragement for the brain injury community. As an advocate for individuals living with brain injury, we here at Synapse at the University of Oregon are so grateful you all decided to join us today for the live presentations. We want to send a huge thank you to all of our wonderful guest speakers joining us today and in the coming weeks. So here with us today, we have Dr. Christina Ledbetter and Dr. Amy Lawson-Moore, who are both on the board of the directors at the Gibson Institute of Cognitive Research. Dr. Ledbetter is a clinical neuroscientist and researcher with a PhD in pharmacology, toxicology, and neuroscience. She specializes in functional magnetic resonance imaging and surgical brain mapping. Along with being the president of the Gibson Institute, she's a part-time research fellow at LSU Health Sciences Center in Shreveport, Louisiana, where she heads neuroimaging research on the neurological and psychological conditions such as Parkinson's disease and epilepsy. Dr. Moore is a cognitive psychologist at Learning at RX World Headquarters and a child development specialist with more than 25 years of experience in developmental and psychoeducational assessment, curriculum development, teacher education, program evaluation, and cognitive research. She has a master's degree in education and a PhD in psychology with a postgraduate study in cognitive therapy. She oversees research at Gibson Institute, coordinating intervention and assessment research for neurodevelopmental disorders, learning disabilities, brain injury, and age-related cognitive decline. Okay, so before we get started, I want to request that if you have a question, to please put it in the chat. We will be referring back to them after the end of the presentation. And before we begin, Daniel, I believe you had a quick introduction yourself.
Yeah, thanks. It's funny because I keep writing this and I'll never get it perfect. I think that, so I'm really happy to introduce Dr. Moore and Dr. Ledbetter, and what their work shows us, I think, is really important for, like, I've been trying to have a discussion with people about working to restore your cognition, and I guess it's relearning is a good way to think of it, but I don't think it exists. It's at least very confusing and hard to talk about. And I get into all other kinds of discussions about it, about holistic treatment versus, I think I had a regimented approach for, it's restoring something that was in me that was lost. And when I found their work and read their publications, I'm like, oh, this is great. This is precise methods, treatment, and a neuroscience of what's happening in the brain that I think it just needs to be discussed. And it's really important that it's out there because I think it will change the way discussions happen. So, you know, with that, it's personal for me. So I'll stop talking and cool. Thanks. So.
Okay, so I guess you're ready for us to start, huh?
Yeah, and sorry, I kind of threw it at you. Oh.
No, that's okay. Let me share my screen. All right, thumbs up if you see full screen. Okay, so thank you, Daniel and Emily, for those introductions. So Dr. Christina and I are going to present cognitive rehabilitation training for traumatic brain injury. And this is based on the work that we have devoted our careers to doing. Really, Emily gave a great overview of who we are and what we do. She did both say that we're on the board at Gibson Institute of Cognitive Research, and that's a nonprofit research institute that is dedicated to improving thinking and learning for people who have recovered or are trying to recover from traumatic brain injury, as well as people that have neurodevelopmental disorders such as ADHD, dyslexia, other learning disabilities. And then we've also focused our work on some age-related cognitive decline, MCI and early Alzheimer's. What we have found through our research, and I'll be showing you some of that in just a few minutes, is that cognitive training is a universal intervention. It's applicable for all ages and all types of brains. And that's the most exciting part of our research. So Christina she is a clinical neuroscientist and her expertise is in functional MRI. So she's going to share a lot of stuff about our research using MRI in just a few minutes. And then I'm a cognitive psychologist. I'm also a former child development specialist and teacher. I'm a board certified Christian counselor and editor-in-chief of Modern Brain Journal, where we focus on publishing research in a digestible way for the public. All right, so we're going to talk about traumatic brain injury and the organization of the brain, and then we're going to introduce the idea of cognitive training, show our cognitive training research findings, and then we'll open it up for discussion and questions. And I'm going to turn it over to Christina now so that she can talk to you. Do you want me to stop sharing and let you share?
I think you might need to do that.
Okay.
Okay, let's see. Yeah, let's see if I can share my screen. Can everyone see the slides? Thumbs up if you can see them. Okay. So TBI is a huge umbrella term. And I just wanted to point that out because whenever we talk about research in regard to TBI, you're really always only talking about a sliver of the big TBI picture. And that holds for our presentation as well. So we're going to be using the term TBI, but again, we're just looking at a kind of a sliver of that TBI population, but our research also focuses on figuring out how big of sliver do we cover. And thus far, for the patients or the subjects that we've studied, we found it to be a pretty large sliver. So TBIs are generally classified as mild, moderate, or severe. And that designation is simply based on the amount of time that there was a loss of consciousness and the duration of the post-traumatic amnesia. It really doesn't say anything about the symptoms that someone is experiencing. And I think we all know that someone can have a mild TBI and have symptoms of that TBI, and their symptoms are anything but mild. And so when we're talking about our TBI classification, we really think about TBIs independent of whatever classification there is. If it's a broken brain, it's a broken brain. And we think that kind of our methodology holds for, especially again, mild to moderate. So there are vast and diverse symptomology for TBIs. They can include anything from headaches to depression to mood swings to cognitive dysfunction, such as problems with memory or attention or concentration, language skills, math skills, problem solving, etc. And as we go through, the rest of kind of just my background, I hope kind of gives some indication of why the symptomology is so diverse. Okay, so the mechanisms of injury. So in general, the skull is vastly protective of our brain. However, there are occasions, especially in traumatic brain injuries, where some injury results from the skull. And one of our classic TBI injuries is temporal lobe damage. And as you can see in this picture, that the skull has these bony ridges. And as they're hard, whenever there is any force, if the force exceeds the protectiveness of the CSF or the cerebrospinal fluid, the brain can actually come in contact with these bony regions, leading to damage or injury to that temporal lobe. Another mechanism of injury is, it's called Coup, Contra Coup injury. And coup contra coup injury reports from whenever the head comes into direct contact with an object, there is an injury at the site of impact, but the force of the injury is so great that it causes the brain to kind of ricochet and then bounce back on another part of the skull. So in coup contra coup, that the injury actually occurs at the point of impact as well as a contra location. So 2 points of injury. As next, the third example of common injuries from brain injury, it's called diffuse axonal injury. And so diffuse axonal injury happens independent of direct impact. So here you have impact, and that impact again is strong enough that this time it's going to cause shearing of different parts of the brain. So this is our gray matter, kind of the outside covering of the brain. And then this is the axons. And so shear injury causes a severing between the gray and white matter. And so then this is localized injury, but it's not necessarily at the site of impact, but at a different locale. And this is just showing, again, so what you're seeing in this figure, these are the white matter tracts of the brain. And these white matter tracts are what facilitate communication from different brain regions. So you can imagine that if you have a shear injury that severs these brain connections or this wiring, then there would be a functional deficit at the location of that shearing. And then with injury, you can also have hemorrhaging. I think this picture says 1,000 words, that the blood supply to the brain is vast. There are blood vessels all throughout. And so you can imagine, just like if you incur a bruise on the end of your body surface, that if the brain comes in contact with something hard, such as the skull, that these blood vessels can burst, leading to bruising or hemorrhaging within your brain. And then wherever that bruising or hemorrhaging occurs would lead to focal injury at that point of the bleed. Okay, so we kind of went through different mechanisms of injury, and now we're going to look at how those injuries can lead to different deficits. So if you had an impact to your frontal lobe, then you might expect to see deficits in executive skills or higher cognitive function, such as memory or language or auditory processing. You could also experience deficits in judgment and impulse control, social or sexual behavior, or have personality changes. And that's all resulting from potential damage in the frontal lobe. If there was damage in the temporal lobe, such as by those bony ridges in the brain, then you might see deficits in emotions, sensory processing, perception, memory. You might become aggressive or have language deficits or have deficits in auditory processing. Parietal lobe damage generally manifests with symptoms related again to sensory processing, eye-hand coordination, as well as language or auditory processing. And in the occipital lobe, which will be common for those coup contra coup images, where the brain hits the frontal lobe and then the occipital lobe ricochets with the back part of the skull. And so that might lead to deficits with vision, for object recognition or facial recognition, and visual processing. Okay. So now we'll kind of look at regional brain injury and loss of function. So no longer do we think about brain and function as one region, one function. Just like everything else in the world, it's really driven by networks of communications. And your brain is the same. Your brain consists of multiple networks where functions are driven by network communication. you have kind of your baseline, they're called resting state networks. So these are networks that are going to be active when you're not actively pursuing a task. So if you're not actively reading, then you would see activation in resting state networks. Then if you switch where you are actively pursuing a task, such as that involves memory, attention, or language, then you're going to see activation of networks associated with that active task. And so a lot of what we do is that we study network function in traumatic brain injury. And why this is significant. So I love this analogy. So what you're looking at here in this figure, this is your working memory network. And you can see that there are five key regions in this one figure. Well, if you're going to have superb working memory function, you really need excellent communication with between these 5 brain nodes. But if you were to knock out a node, so maybe if there was an injury in the right frontal area and you lose that node, then all of a sudden your working memory is going to decrease. You're going to struggle with working memory. And this car analogy, a car runs great with 4 inflated tires. If one tire goes down, the car can still run, but it's not going to be nearly as effective when all 4 tires were aired up and ready to go. And this is also a perfect example when you think about network function. So if you had that, so working memory is a common complaint among survivors of TBI. Well, but that complaint can do, so if someone has a frontal injury, a parietal lobe injury, or left or right, all of those can kind of manifest with the same symptomology of impaired working memory. And this is the good news is that, so when the brain, since the brain is kind of works on a network level of connectivity, that one node, so if we have one area of injury, the brain is wired to be able to route around that node. So if you have an injury here, and let's say it's a severe injury where you've severed the connections, then what you have to do is the brain has to find a detour. And that's hard. But cognitive training is about presenting a task. And in the beginning, that task is hard and challenging. So for example, maybe it's a working memory task. So you challenge the working memory. It's hard because you're really trying to drive that neuroplasticity to find a detour around the injury. And the more you practice that task, the more you drive that neuroplasticity, which kind of leads to the...
Can I ask you a question?
Yes.
So I think in the last slide, I really appreciate how you said that. I think that the frustration in my experience and the level of how much it is hard, I think people don't always understand that's going to happen, and people don't always understand that's happening to us. What do you recommend for, like, I don't know, helping people deal with that? Or is there anything like with your patients?
From the patient standpoint, or from the care provider or the outside? Which standpoint?
Good point. I didn't even think about those distinctions. I guess for both, or for the patient is what I was asking.
So from the patient standpoint, I think it's, so if the patient understands what's happening. So when someone's learning a new skill, and we learn new skills our entire lives. You fall down and you have to persevere. And so perseverance is hard, but I think if you have that visual picture of, yes, I am persevering and what I'm doing is just chipping away and driving this neuroplasticity. Yes, I'm having to work at remembering this task, but the more you do it, the more potential for success, because you're basically driving new connections, driving new brain plasticity.
Yeah, I think I think of that analogy as good when, like, you learn extreme sport because it's so thrilling. But when you're doing something that used to be automatic and you can't do it, it's the most frustrating. I think that that idea can be promoted or discussed more. But yeah, otherwise it is that chipping away.
I would like to add to something that Dan brought up. when you made your presentation on the structural and functional brain network connections, and you talked about it as in the context of cognitive remediation, I'm wondering if there's anything you can speak to about from the emotional side of the trauma, emotional impact.
The emotional impact from emotional dysfunction, or just emotion from a traumatic experience?
Yes to both.
So, I mean, so
But
you
certainly in the context of what you first brought up, being the functional dysfunction, or that didn't come out right, but
Okay.
the dysfunction. There's an organic dysfunction. I'll call it an organic dysfunction as a result of physical injury, shearing at the cellular level, whatever. And
right.
then there's the emotional impact of trauma, period.
Yes.
And in the context of what you were talking about in these networks, and we're just wondering if there's anything you can elaborate in the context of the emotional remediation as opposed to the cognitive remediation.
Can I say something real quick? Just because I'm
Sure.
literally researching this and writing an essay on it right now. And then I think that's the huge problem, especially with the emotional stuff, because the overwhelming feelings are real. And then we don't even know if the circuits underlying what is producing the emotional feelings are injured or not, but the feelings have to be dealt with. And I don't think that.
Good point.
Yes, I don't think we, like, as a scientist, if I wear a scientist hat, I'd say you can't really know, but I think that all the networks in us can be improved in the same ways. And I'm personally going through the emotional healing right now. It's very difficult. I think I ignored it for 20 years or so. So it's like what's underlying the feelings can be injured or changed, and then the feeling part which we experience can just be altered even more. But I think you can only go through it through the feelings, and there's a lot to talk about there, like with the use of psilocybin and other drugs to deal with the PTSD side of TBI. There's so it's hard to know.
Can I ask? Can I ask your perspective on? So my name is Maz Bonato, and I have had a brain injury for 40 years. So I really have challenged myself for a very long time. And speaking of emotions, the idea of neuroplasticity has been the most emotional idea, because I've put myself to the task of recovering. And when I hear people talk about neuroplasticity, it's misleading, I feel. So I wanted to get your perspective on my experience is that I can do something, but it takes a very long time for me to get that information to my working memory. And then it replaces everything else that I might be able to do, including recognizing food in the fridge, and including being able to, do the most basic of skills, because I'm using my working memory to do this thing that I set up these steps to do. So when you talk about, it's hard and you go and there's neuroplasticity, I have it very different from a experiential perspective of what that means. And so I feel that when I hear scientists talk about this, that it's very misleading. And I became suicidal over the idea that people were telling me I should have recovered by now.
And so in regard to what you're talking about, and so our cognitive training, the research that we're doing with this cognitive training, it's a little unique than traditional cognitive rehabilitation.
I had no rehabilitation. I had to do it all on my own.
And in our opinion, that is where the field needs to change. There is plenty of research out there that suggests that cognition is absolutely worthy of rehab effort. Because, for our research, so if you were to do like a working memory training.
My perspective is, I wanted you to comment on the idea that the neuroplasticity isn't permanent. It's not to do a skill. Yes, if I'm focusing on that, it takes a while to get those steps set up. I don't think I can do it in any other way, even if I had training, that there's no way that I can do multiple different things while I'm focused on the one thing. And it takes many days, weeks, months, even years to do that task. And it completely takes over all my attention. So I can't even do the most basic of tasks. So that is what I get frustrated when I hear the neuroplasticity concept. I have many talents and I can do those many talents, but it's at a cost. And so that's what I wanted to get your perspective on. Do you understand that it's at a cost?
Absolutely, it's at a cost.
So that you can achieve a task, but it's taking away from so many other things. That is livelihood.
Can I speak to that too? So I hear your frustration, and
I'm somebody who's
when we talk about cognitive rehabilitation.
Can I say one more thing?
Sure.
Many of the people here on this lecture and others that you might meet, they have support networks. Okay, I have no family. I have nothing. I have noticed that when I did have partners and things, I can copy them, and their prompting and stimulus that there's not an awareness until it goes away. And so a lot of times you can achieve something in a certain environment, but then it's completely lost when that situation changes, because those just innate prompting and stimulus that happens in an environment with social supports within the home are not there anymore. So I really have been in many different environments and seen the limitations of neuroplasticity. So my frustration is not in what I can do, but I understand how I can do it and what I can do. But my frustration is in the experts who don't have a brain injury, not understanding that neuroplasticity isn't all that you're making it to be.
Maz, can I say, the thing I wanted to say in the beginning of this is like, what they have to show work-wise is like, in a perfect world, it's like a gold standard that doesn't even exist.
Yeah.
Because
and that's what
availability of resources isn't there.
I have been attacked by doctors.
Yeah.
And I have not had support, because doctors have to make the recommendations for that support because they don't believe, because they're being taught that there's neuroplasticity.
Well, there's like 100 other holes, and I know we've spoken and emailed where without support, like the clearest data shows that. And
I have become suicidal because these doctors are drowning and driving this idea of neuroplasticity, which is not in the way that you're picturing it to be.
Well, the neuroplasticity, I think, is still the same. It's the other factors that have made what you're trying to deal with. And most people I speak to are kind of like in your situation. They're just trying to put it together on their own, and they don't have all these other supports. The plasticity is like this. And
I will never have those supports. My life is just that way.
But isn't that the problem? Isn't that the really big issue that needs to be addressed? And so, their talk is very important. And then to see what they have, setting that as a standard to try to build, it's ridiculous that the supports don't exist. I'm finding it overwhelming the more I see it, but that's really the problem. It makes it even more frustrating that good work is out there.
No, the problem is that they don't understand that the supports and how the supports interwork with what they're seeing as achievements, and that they're aligning that with neuroplasticity, but it's not the neuroplasticity. It's an interaction of what they're
they don't see it, and they
assessing.
Can't see it, and that's okay, because at this point I don't think people with brain injuries have reminded me they can never understand it.
Yeah.
So given that,
but I just wanted to get their feedback on the idea that maybe you're driving something with the wrong concepts.
Right.
That there's concepts that are beyond you're doing this. Oh, where's good news? There's neuroplasticity. Not really.
my feeling of the neuroplasticity that they're going to show towards the end of the talk and in the changes they show in patients, it took me like about 5 years to really feel it. And the progressions before that was when I had full support and I was only focused on this 100%. That's why the precision of what they show is
Yeah,
fascinating,
but I
even
do a
though
lot
it
of different
exists.
things. So
Right, but
if I just
that's
did,
what I'm
if I
saying, that
just
there's
did
the
the,
issue of support.
if I just
Yeah.
did the one thing that
Yeah.
they're concentrating on, it'll look like I've recovered. But I do a lot of different things. I own my own home.
Right. Well, you'll be
Okay.
surprised the dimensions that they show about. And yeah, I mean, thanks for sharing. I think
Yeah, I'm done.
many of us are not saying what we're experiencing. So yeah.
Okay. Okay, so let's hold questions to the end, and we will continue going through the talk. So kind of the basis of cognitive training is that neurons that fire together wire together, and neurons that are out of sync fail to link. And so cognitive training is all about getting multiple cognitive skills. So if you're working on working memory and you're working on attention, to get your working memory neurons to fire together, as well as your attention neurons, and driving that interaction. And so Dr. Moore will talk about the cognitive training methodology that we have used in our research to accomplish this. Okay.
Okay. Let me. Okay, here we go. So I just want to briefly describe what's involved in the method in the program that we have been conducting research on. And it's a program through LearningRx, which is a worldwide network of cognitive training centers. And the cornerstone of the methodology is that it's delivered one-on-one by a human being. So it's different from brain games that you would play on a computer. This is actually sitting across the table from a clinician who delivers the program. It's customized with multiple training procedures, and I'm going to walk through some of these individually. So like I said, it's one-on-one delivery. It's applicable across ages, but this is just what that training environment looks like. It's individualized because we do comprehensive neuropsych testing at the beginning of a cognitive training program so that we can get just a baseline idea of cognitive function across multiple cognitive constructs. But then we also use the first couple of training sessions to gauge practical functioning in all of these areas. So we don't work on skills where you have strengths. We work on skills where you're struggling. But as I'll show in just a minute, our cognitive skills overlap. We don't use them in isolation. And those brain network slides that Dr. Ledbetter showed, demonstrate that. And I'll actually do a quick task with you guys in a second to show how that looks like practically. But these are just some examples. Everything that we do is very hands-on. We have over 100 different training exercises. And each of those training exercises has 10 to 12 variations. So it gives us about 1,000 different ways to train multiple cognitive skills. And each of those training tasks is sequenced in order of difficulty and complexity. And so, we kind of find the level of functioning at the beginning of a program, and we start you there, and then we work our way up through each task and each level of difficulty, and we train it to mastery. And most of our tasks are paced with a metronome. And for a survivor of traumatic brain injury, that can seem overwhelming. And so we will start low and go slow, but it's actually pretty amazing how our research participants with brain injury will adapt to the metronome eventually. And what that metronome does is it enables us to really work on increasing processing speed gradually. It creates a more intense training session, kind of prevents you from taking a mental break. We like to call it creating a mental sweat. But again, we are sensitive to the differences in the etiology of each of your brain injuries. And so we meet you where you are and work from that level of functioning. Many of our tasks are also speeded. So we use a stopwatch and we gradually push each participant to get a little bit faster on each of those tasks. And then because we don't live in a vacuum, the world is full of distractions. So we actually use distractions in the training environment. And we have two different types of distractions. One, the cognitive trainer will intentionally add distractions to a task by saying the opposite answer, singing, telling a joke, anything that they can do to really engage that sustained attention for the participant. But then we also have environmental distractions. That picture on the right shows what a training environment looks like. And you can see there are multiple training sessions set up next to one another. And so you have multiple people training at the same time. They're doing different tasks. So you hear lots of different voices, metronomes ticking at different rates. And again, if we did these training tasks in a quiet, private office, then that's not going to mimic the real world where you're inundated with lots of external stimuli. And so we want you to be able to focus in the middle of that stimuli. Again, we recognize that that can be overwhelming as you're recovering from traumatic brain injury. And so we go slow and work your way into that. So another key element of this methodology is complexity. So according to the most widely recognized theory of intelligence, the Cattell-Horn-Carroll theory of cognition, there are 18 broad cognitive skills and more than 90 narrow cognitive skills. That's a lot happening. I mean, we're talking working memory, long-term memory, processing speed, attention, visual and auditory processing, reasoning skills, and then lots of sub-skills underneath those. And so because cognition is so complex, cognitive training also needs to be complex. And so we recognize that as we're training skills, nothing is being trained in isolation. So I want to do a quick demonstration just to show what that looks like in real life. So I'm going to give you 10 seconds, and I want you to spell the last name of the first United States president backwards. Ready? Go. All right, stop. This is what the answer looks like. And I meant to say do it in the air, not with a pencil. Was it hard? I want to walk you through what your brain does in order to accomplish that seemingly simple task. So first you have to remember who the first United States president is. That's long-term memory. Then you have to decide on a strategy for completing that task. That's logic and reasoning. Most of you probably projected the word Washington either in your mind or into the air. That's visual processing. You had to determine which letters go in the word Washington, and so that's auditory processing. You had to remember which letters you had already said and which ones are coming up. That's working memory. About halfway through that task, you might have gotten frustrated or distracted, and so you had to engage your attention skills. And finally, I only gave you 10 seconds to do that task. So that's processing speed. So that one really short task engaged 7 different cognitive skills. So thinking is complex, and therefore cognitive training also needs to be complex. And so that's the basis of our methodology. And then in order to drive neuroplasticity, you need to create intensity. So those experiences have to be intense, repeated, frequent. And so this methodology does training sessions for about 90 minutes, 3 days a week. over the course of 12 to 24 weeks, depending on how much training is actually needed.
Can I ask a quick question about that? When you hit, or if you hit the fatigue point, what do you do about that, especially in the beginning when you're trying to calibrate?
Yep. So we absolutely allow our participants to take breaks when they need it. And what we find is, if you can only do 20 minutes the first time, then you can only do 20 minutes, and we'll work your way into the ability to do a full session. We're not mean.
Right.
We absolutely recognize the need for that.
Yeah.
Does that answer your question?
Yeah.
Are these offered in Washington?
So yes, we can get you a list of all of the providers.
Oh, that'd be great. Okay.
Yeah.
Thank you.
Mm-hmm. And like I said before, so we do careful measurement prior to beginning and then again at the end, so that we can measure progress quantitatively, but we also look at those real life changes as well. And so that's really what we want to focus on, to show you that this does transfer to real life benefits. So in our research, what we've done is we've created a convergence of evidence. And what that means is that we've taken multiple sources of evidence. So we've done controlled studies, randomized controlled trials, propensity matched controlled trials. We've done case studies, pilot studies, and then internal client outcomes, that from the clinicians who deliver this program. And we've combined that. Sorry, my mouse isn't working, with multiple types of evidence. So we use standard neuropsychological tests. We use functional MRI. We've used quantitative EEG. And then we've also done surveys and self-reports and interviews so that we can determine what real life changes we're seeing. And what that has done is it's created this convergence of evidence that supports the methodology. I do want to mention that this program was originally designed for children with learning struggles. And it was designed back in the 1980s by Dr. Ken Gibson. And he used it for a couple of decades with children, and then said, wait a minute, if this is working with children, might this also work with adults who have age-related cognitive decline? Well, if it's working with adults with age-related cognitive decline, might it also work with brain injury? And so we gradually added different populations to what we were studying, and found that it was working, and regardless of age and regardless of diagnostic category. So the majority of our research is published on children with learning struggles and children with ADHD. And then we also have several studies published with older adults. And finally, brain injury, which is what we want to talk about today. So what have we found with our results? Well, in terms of cognitive improvements, we're finding significant changes in those cognitive constructs that we've talked about. So memory, processing speed, reasoning, visualization skills, attention, auditory and language processing, and even increases in overall IQ score. But the changes that really matter are the changes in real life functioning, right? We can get excited as clinicians and researchers about changes in test scores, but you want to see changes that impact your day-to-day life. And so the number one change that we see is an increase in confidence and self-esteem. But we've also documented changes in self-discipline, cooperative behaviors, better relationships with others, improvements in school and work performance, better sleep habits, better driving, increased participation and performance in sports and hobbies for kids, better attitudes about school. We've really seen with our adults improvements in mood, decreased anxiety, and a better outlook on life. It gives them a sense of hope. And then we've also documented changes in the brain. So changes that are measurable with functional MRI that have shown changes in brain network connectivity, better overall cognitive efficiency, changes in white matter integrity, and those changes in the brain that directly correlate to changes on cognitive test scores. And Dr. Ledbetter will show you some of those MRI results in just a minute. So the evidence for using this methodology with brain injury, we're going to show you from 3 different sources. So observational data from real life client outcomes. So not research participants, but in real life clinics, what's happening. Then we're also going to show you some published research that we've done with soldiers recovering from moderate to severe TBI, and then some neuroimaging case studies that we collected and published. And those brain injuries were of varying severities and causes. So we looked at changes. These are real life clients, 163 children who had a brain injury, and these are their pre and post percentile scores using the Woodcock-Johnson battery of tests. They had an average gain in IQ score of 11 points. You can see the significant changes in each of their cognitive skills. And then with 223 real life clients with TBI, the same types of changes across all cognitive skills, average gain in IQ score of about 10 points.
Over what period of time are these results?
This was
measured?
2010 to 2018.
Oh, okay. I'm sorry.
And then we looked at their—
how many hours, Randy asked one question about how many hours of work are you actually doing with them?
60 to 90
hours.
Right. Yeah. Over, so if you do 3 to 5 hours a week,
right,
it's anywhere from 12 to 24 weeks.
Yeah, that length, I think people don't think about that. And then it does the frequency but it's only 80 to 90 hours. Oh, I just wanted to.
And over what period of time?
12 to 24 weeks.
Oh, sorry.
12 to 24 weeks. Okay.
Yeah.
Okay.
So these are the real life changes that these clients reported. So for adults, again, improved organizational skills and productivity at work, even better writing and communication skills, their perseverance and diligence and coping skills when they're challenged, increased in confidence and hope and optimism. Again, the driving ability. It's interesting to see the improvement in social skills in adults as well as children. And so the children—
Can you elaborate on that?
Say one more time.
Can you elaborate on what you just said about the social skills?
Right. So it's just interesting to see or to hear adult clients report back that they're getting along better with people at work, that they're communicating better with their significant others or with their children. It's like because their anxiety is lessening and their mood is improving, their relationships by default are also improving as well.
Well, this touches upon what I brought up earlier with Dr. Ledbetter, and that is the emotional results from the injury.
Mm-hmm.
So much of what you're talking about here are emotional issues.
Yes.
Certainly cognitive, but certainly emotional as well. I mean, it's not like it's, you can draw, it's not a clear-cut line.
Right.
And everything that I got in on this late a little bit, so maybe I missed something, but what I'm thinking is that everything that you're doing is in, how do I put this? In the physical sense of doing something, a process, if you will. How is it that you're seeing the results of the emotional remediation from the exercises and the processes that you're presenting people with? How is that coming about?
Yeah, so I know that Dr. Ledbetter has an opinion on this as well, but let me just say first, a lot of what happens after brain injury is an enormous amount of frustration with reduced capacity for thinking and learning, right? So you're frustrated about your memory, you're frustrated about your ability to process information efficiently. And so when you strengthen those cognitive skills, by default, you are reducing that frustration. And we know that frustration and that anger that is turned inward can manifest as depression. It can manifest as anxiety.
Lots of different things.
Yes,
Yeah.
we know that the connection between the amygdala and the prefrontal cortex, when your stress level is high, right, that your amygdala is going to hijack your prefrontal cortex, which reduces your cognitive abilities. And so anytime that we can strengthen the cognitive side, then we are, again, like I'm saying, by default, seeing those improvements in behavior, which
That
are a
actually was
result
a
of
pretty
how
good
am I
an-
thinking.
I got to tell you, I thought that was a good answer. So continue.
Okay.
I'm sorry.
Okay. Dr. Christina, do you have anything you wanted to add to that? Okay. All right. So then again, in children, improvements in school, reading comprehension, their ability to focus on their schoolwork, better self-discipline. They take the initiative to get things done because now their cognitive skills have either been remediated or sometimes even better than they were before, right? But the optimism and the improvements in self-esteem are just beautiful to see, which then, you know, the improvements in cognition are translating to real life focus improvements as well. Okay, so those are real clients. Let's talk a little bit about research. So we did a pilot study with soldiers who were actually in a warrior transition battalion unit. And you get put in that unit when you've suffered a brain injury that's severe enough that you have to go through multiple types of rehabilitation, so both cognitive and physical, sometimes speech and language therapies, to determine if you're able to stay in the military or not, or if they're going to medically discharge you. And so we went in to do this methodology as part of their overall rehabilitation process. And so you can see that it was diverse times since their injuries, diverse types of injuries from blunt, blast, and penetrating. We did have one aneurysm, which was acquired. And mean age was about 34 years old. So they were originally supposed to do 60 hours of human delivered cognitive training supplemented with 30 hours of digital exercises. So we have a digital program that mimics the one-on-one delivered exercises that we use either as a warm-up or a cool down or just to supplement the one-on-one training, not to replace it. So you can see a clinician delivered task on the left side of that picture, and then that same task that they can do for homework or as a warm-up on the computer. We did have several people who were not able to do the digital tasks. Either the lights from the computer were overstimulating, or it gave them headaches or something like that. So kind of a diverse amount of completion in terms of the supplemental training hours.
Can I ask a abstract question?
Yeah.
What do you draw the line between the supplement versus the real person interaction? Because I think the real person interaction is so important.
Yes.
So like, is the supplement quantified or?
So we do at most 30% of the training program would be delivered digitally. So 70% at least needs to be delivered by a human. Okay, so this is just showing our statistical significance testing. So you can see overall as a group, significant changes in 5 of the 7 skills that we measured, but changes nonetheless, even if they weren't statistically significant in all of the skills. And then we wanted to look, because again, from a research perspective, group results are great. From a real life perspective, we want to look at those individuals. And so we looked at clinically significant change as well. And so how did each patient compare to where they were functioning at the beginning to if we compared them to a non-injured group? And we do that by looking at the reliable change index and clinically significant change, which we do algebraically, actually. All right, so here are the results of the clinically significant change. 70% of the scores at post-test met that threshold, meaning that 70% of the scores would have been what the scores would be in a non-injured comparison population. And then when we looked at the reliable change index, 91% would be considered recovered if we used overall general intellectual ability as our metric. So I'm not suggesting that from a functional day-to-day living, they were completely recovered. Statistically, they were 91% could be considered recovered, but all of them were able to go back to work, active duty, all of them. And several of them went back to school and finished degrees. So that tells us that their lives were changed. And we saw gains across causes and severity.
Yeah, I think
I'm going to turn it back to Dr. Ledbetter because she's going to share the most exciting research on neuroimaging that we've done as well as, let me stop sharing. Okay.
Okay, so this is, I think, one of our most recent TBI and neuroimaging publications. And what we did for this was we wanted to look at some case studies where so in a case study, you actually get to know the research participant, you get to ask detailed questions, and case studies are beneficial in that they help us drive better research to know what's relevant on a single patient's level. So rather than purely looking at group statistics, we're able to examine in detail each person's outcomes. And for the study, we looked at pre and post EEG with quantitative analysis. We did pre and post MRI. We did pre and post cognitive assessment. And then we did pre and post rating scales that looked at actual behavior, not necessarily cognitive, but daily activities of daily living. And so for the study protocol, these were adults that completed 60 hours of the ThinkRx or Brain Booster one-on-one cognitive training program.
Actually, they were adolescents and adults.
Oh, adolescents and adults, that is correct. And the goal of this study was to determine if changes in brain connectivity associated with cognitive training were evident, and if those changes could be quantified using MRI imaging or EEG. And so for the MRI imaging, we looked at structural connectivity using DTI or the white matter tracking, as well as functional imaging, looking at resting state connectivity in different brain networks. And so for the resting state connectivity, the most robust network is called the default mode network. And we were interested in that because the default mode network is relatively easy and consistent to see on single subject imaging. So you don't need to average a bunch of patients studies together to be able to identify the network. It's identified on a single individual. And so, and the default mode has a lot of clinical significance, that it's involved in stimulus independent thought, as well as self-reflection. It's involved in cognitive and executive functioning. Abnormal connectivity has been associated with pathological conditions, and abnormalities can be increased connectivity as well as decreased connectivity. And so whenever you're looking at, I just want to give you a brief overview of whenever you're looking at this picture, what you're seeing. So this is one region of the brain. And we talked about in network connectivity, this region of the brain would talk to another region of the brain and other regions of the brain. And how do we assess, can they talk to each other? You measure, essentially you use functional MRI to measure the signal at one area, and then you measure that signal at every other area. And so when you see these warm colors, you know that the signal in one area, for example, this red, is very much related to the signal in black, the signal in another area. So when one region is on, the other region's on, and they kind of alternate together. And so we consider that connected. But you also have other brain regions in your network where when one region's up, the next one's down. And those are called anti-correlated, kind of like if when you're dancing, you're anti-correlated with your partner. And what we know from network theory is that anti-correlations are super important. It's the fine tuning. And you can just imagine it. So if you're dancing, that ability to move in sync is very, very important. And it's almost harder than everyone just moving at one time. So for the default mode network, when you evaluate default mode connectivity, you look for these four. So we look for connectivity with this one region at the top, and we look for connectivity with the other three regions where they're positive or in sync, as well as connectivity with these four blue areas. And that's more the fine tuning. So in our case, so this is just the profiles for the participants in our research study. And we intentionally wanted them to be varied because we're trying to gain intuition on who would benefit most from cognitive training. So the first participant was 20 years old. He had had 5 sports-related concussions in a relatively short period of time. He went from a straight A student to being depressed and struggling academically. We had a 16-year-old who had repetitive concussions from playing youth football, and he struggled with attention deficits. We had a 15-year-old who had an injury when they were a child. So we're looking at someone about 12 to 14 years post-injury. Then we're looking at someone who was 35 years old who suffered a car accident, and they came to us about 2 years after injury. And then someone who was 19 years old who'd had a sledding accident 18 years. So again, so these cases were all varying times between when they began cognitive training and when they suffered their injury. And then the last case in this profiles was a 22-year-old who'd had an acquired brain injury as an infant and had suffered cognitive deficits as a result of that. So again, a wide variety of case presentations.
Are default mode networks anything comparable to like a fingerprint among people? Or is everybody's in the same?
Yes, it is essentially the same. Yes.
Okay. Okay.
And so what we found from a group statistic point is that there was significant improvement across all cognitive skills. So they had improved working memory, long-term memory, visual processing, auditory processing, processing speed, and logic and reasoning. And they had about a 23-point improvement in their general IQ.
Let me just jump in there real fast. If you look at processing speed, which is PS right there, processing speed in our experience is one of the most intractable skills to train. And as brain injury survivors, you know how difficult it has been for you, I am sure, to process information quickly. And so to get that much movement on processing speed is really exciting for us as researchers, but also for those participants to feel like they're able to process information more quickly after training.
Yes, and so then we also looked at we in a small pilot study we used MRI to look at changes in brain functional network connectivity. And so in this group, we saw significant training-induced pre-post changes in connectivity with the thalamus and the caudate and the cerebellum. So just several regions that would be associated with cognition. Then we also looked at changes in structural connectivity. And so that we found 3 white matter tracks where there was a significant change in connectivity or structural integrity after training. And so this is an example of one of the clients, the one that was 20 years old who had experienced 5 sports-related concussions. So this was his pre-training MRI. So again, up in the left-hand corner shows what's normal. And you can see how he was just missing the integration of this brain region. So if you look at it, his structural MRI is read as completely normal. So you could look at this and say, oh, your brain is fine. You should have no issues. You're fine. However, when you look at this region's ability, how it's communicating with regions that it should be communicating with, there is a deficit. And then after training, you can start to see the reintegration of this node and kind of starting to see more normalization of connectivity. And so, great, you see changes in imaging, but how did that affect this function? Well, this individual was able to return to college. So he had improved functioning and went from being, so he was initially a straight A student to a struggling student, then to be able to continue his education. And so I am going to let Dr. Moore talk about just these next 2 slides, because this is really her area of interest.
So we also interviewed them at length prior to beginning the training program and then again at the end. And so what we found was super interesting. We didn't revisit with them what they had said prior because we didn't want to contaminate their responses at the end. But what we found is that nearly everything that they reported as being symptomatic about prior to the intervention were the same types of things that they reported that they had improved at the end of the intervention. And so, you know, in patient number 1, you know, talked about having memory loss and the inability to drive and loss of social connections. Well, this patient actually resumed her ability to be able to drive. Her processing speed was super slow. And that was one of the reasons why she was struggling to drive. She just couldn't manage all of the fast moving stimuli. So not only did she resume her ability to drive, she also got a job at Starbucks as a barista. And so you know how fast paced that environment was. And that was a win for her. So just really neat to be able to see those improvements at the end that they had really been struggling with at the beginning. Next slide. Oh, right. And so then we did a qualitative thematic analysis of what they had reported and came up with 5 themes. So the most frequently cited symptoms prior to the intervention were in cognition, in mood, in their social identity and relationships, in their work or school performance, and in their activities of daily living. And then at post-intervention, those same themes revealed improvements in each of those areas. And that was across participants.
And so then I want to kind of end with, this is one of our, we talk about this case study all the time. And so again, so this was research. And so when we went into doing this research, we had no idea what to expect. This was an individual who was 8 years post a severe traumatic brain injury. He was biking, had a bike accident. They did not find him for hours. They thought he had passed away. When he got to the hospital, he eventually recovered physically. He had to learn to walk again, talk again. So this was definitely a severe TBI. And the general assumption is that after about 3 years, you have recovered to the max that you will recover. And so this individual was 8 years post. And so we didn't know if we could help him, but it was one of the benefits of being able to do a case study. So we enrolled him in this research project and did our pre-post imaging. And so from a cognitive standpoint, he really, like a lot of the TBI survivors, struggled with processing speed, impaired, and for him, all of his pre-cognitive functioning was debilitating. He was an engineer, and after his brain injury, he could no longer work as an engineer. He was eventually able to secure a job, but it was very different than his pre-injury status. And with 60 hours of cognitive training, he had a significant improvement across cognitive skills, with a 21-point gain in IQ, improved activities of daily living, and an improved emotional score. So again, we were able to measure improved cognitive function. Then from an imaging standpoint, this was what his pre-MRI looked like. And this is very classic of brain injury as well as early cognitive impairment, that what you see is he's lost all those fine tuning, all the anti-correlations, and there's this hyperconnectivity pattern. Well, after cognitive training, you begin to see some normalization of that default mode network. And with the QEEG, his initial showed decreased beta activity in the frontal lobe, which was normal, which can be associated with mood, depression, and memory deficits. But post-training, you can see normalization of the QEEG. And so basically, we've quantified improved cognitive function, we've quantified improved resting state connectivity, improved QEEG, but it was his statements that really, I think, reflect the significance of this, that he talked about that his motivation was better. He was better at staying on task, getting things done. He always talked about going off on a rabbit trail and how much that improved. And I think that the biggest things were, not only did he have the 23-point gain in IQ score, he was able to, after 8 years of injury, he was able to return to his pre-injury job. He went back to being an engineer that he was 8 years past or previous.
Question. How this fellow was 8 years post-injury when he came to you?
That is correct.
Is there anybody that has come to you that is where that gap in time from the time of the injury, the time they came to you, has been longer than that?
We
20 years, whatever.
So yes,
I'm sorry?
One of our case studies was 23 years post-injury.
So what happened with that person?
So honestly,
how well did that work out?
How do you know, Amy? I don't have those in front of me. I'm sorry.
Are we talking about from the cases?
Yeah.
I'm just generally your experience from the time that somebody was injured. Has anybody ever come to you who was, 20, 30 years post-injury, like Maz who spoke earlier?
Right. So we had a 16-year-old in our study who was injured as an infant, fell out of a shopping cart. So that's 15 years later.
Okay.
He's now in the Marines. We had one who had the cerebral hemorrhage his first week of life, and he was 22 when he came to our study. So 22 years later, and had struggled with cognitive deficits his entire life.
I'll bet. I was just thinking that they're even tougher because the injury occurred and they're going through development.
Right. And in the absence of an intervention.
Yeah.
Because we know the school system puts Band-Aids on
If that.
neurodevelopmental issues.
Right.
They don't remediate them.
I think most of the people we meet in the groups, I've met Randy in person and then online in the groups. Most people are in that situation. And I just wanted to touch on kind of putting this all together, because looking at the brain scans and then looking at their quantification is never going to reproduce what we're going through. But there's the whole point of this talk series is thinking about these brain systems. They're not like fingerprints, they're systems in us that work, and with the right promoting and understanding of what's happening in us, we can encourage certain ones. And what their work is showing how, like, the best way to do it. So every person is going to have all these other changes and issues in them, and we go through it. And I think we get frustrated when clinicians talk about what we're experiencing, because they have snapshots of the systems, but the overall improvement is so possible, and just has to be done right. And that's why this data is really awesome, and the way you guys are dealing with it is just so important. So
well, and let me just say too that I was reading the chat while Dr. Ledbetter was talking, and it makes me sad that we lost Maz. Is it? I had an overdose of anesthesia 13 years ago, and I understand the frustration at least a little bit. Right. I lost 6 years of memory from it, and really struggled with working memory until I got some brain training as well. And my oldest son had post-concussion syndrome from repetitive concussions in middle school, and missed an entire year of school over it. So to work through the emotional fallout, in addition to the cognitive deficits, I understand from a parent's point of view, from a personal perspective, and also as a clinician and researcher, I get at least a little bit. And so we've devoted our lives to studying this because we want to help. And so I just hope that message came across, that if we don't push science forward, then how do we know what will work and what will help?
I'm getting the impression, and correct me if I'm wrong, that you seem to be taking a, for lack of a better way of putting it, a macro systems point of. So let's say you have to read a systems approach. I mean, is that correct? You're really looking at this whole problem from multiple disciplines, as speech language therapy, neurology, diet, nutrition.
Well, as a brain injured person that went into neuroscience to understand what happened to me, I would say that the macro systems approach is the way it needs to be approached, given what the data is showing about how the brain works. So
no question about that.
That's the framework with why we need to look at what the brain is doing, plus all those other caveats. So yes, it is multi-layered, and that there's a weird connection between changing what's happening in the brain through our work and then having all these other like invisible improvements happen. And it's not discussed enough. So yes, I'd say yes, right?
This is kind of interesting. Where are you guys, by the way? Are you in Colorado?
Mm-hmm.
Can we answer Nancy's question?
Yes.
Nancy.
One of my questions is about when it's been an old injury that happened during development, in your process of training, does that sometimes require undoing the massive adaptations in order to build more functional connections?
That has not been our experience. Whenever we're doing the training, so the way that you might approach a visual processing puzzle, maybe from a brain network, like how your brain routes to solve a puzzle may be very different than how my brain routes to solve a puzzle, but it doesn't make either right or wrong. So what we do is through repetition, we make what whichever network is activated, activate stronger and more efficiently and faster through repetition and reward. I don't think we talked about it, but one of the key things is that our program does include a lot of reward-based learning. And it's basically, if you complete it, so these tasks are short. So we might have you do an intense exercise for 1 minute. And then if you succeed, there's that personal connection where it's like, great job. So we are your biggest cheerleader when we're
lots of high fives. There lots of dopamine reward from that verbal persuasion and encouragement, that dynamic. I mean, we know in psychology research that the number one predictor of therapy success is the relationship with the therapist. And so if we apply that same idea to the cognitive training environment, we know that when we can create those meaningful connections with the cognitive trainer or the clinician and the client or the research participant, that relationship is such a huge part of motivation and dopamine reward. But I will answer, Nancy, we do sort of have to help children unlearn some auditory processing skills if they have developed faulty ones. That isn't something that we typically see with our traumatic brain injury population, but in children with reading disabilities, yes, we have to do so much more repetition of the proper sound to code partnerships that it has to kind of overlay those original pathways.
Interesting to follow up on that, though. I was one of those kids who had that, who never got help. I'm in my 60s, and my first brain injury was 3 years old. And so it feels like there would be some unlearning, but I don't know.
Yeah. And so, what we know about schema and the way our brain puts everything into file folders, we can change that original schema. We can change that original, map that we have of each concept by just putting a bullseye right in the forehead. Wow, that's it now, because we just do it over and over and over again with the new information.
And do you do those functional MRIs with everybody or just your special case study people?
So just with research. So functional MRI isn't typically used clinically. It's not used diagnostically. It's really a research tool.
And then if you're lucky enough to be a person in the research, well, how does that happen? And does that person have to pay a whole bunch of money?
So these participants didn't pay anything to be in the research study. We had funding for that. So we're actually in between studies right now. We've written a couple grant applications waiting on more funding. So we're not actively recruiting anybody at the moment.
Let's see. And we had a question from,
Riddhi.
Hi, Riddhi. So my question was, I find this all really interesting, but I wanted to know a little bit how many of your case studies and generally clients, patients are doing or have they come from having done treatment for PTSD and vestibular therapy and all these other types of things that are typically done with post-concussive syndrome, or are they doing alongside your program or after? What is typical?
Yes. So we see a wide variety. Sometimes we're the first treatment that they've ever tried. They were just told to rest and recover, and it never happened fully. So now they've, come to us for cognitive training. But we've had several research participants who've tried everything else already, from infrared therapy to tapping to
EMDR and Cairo and the speech therapy and all that. Okay.
And it really also depended on the type of injury. It's interesting. Dr. Ledbetter said in the beginning, that you can see people who have a brain injury that's classified as mild, but have the worst cognitive fallout.
Yeah.
So, yeah.
If I
So-
can I make a distinction real quick? I think that the other therapies that I've viewed, and I mean, I didn't even do them because it didn't make sense for me, but the cognitive therapy and doing work to restore what is missing is very strange and very difficult, and you need to have like all the other things in your life basically covered so that you can do it, because it's so exhausting and difficult, especially in the first couple of years. One group that I've been watching is the I Am Aphasia in New York, and they went from one group to 3 groups to 10 groups, and they're helping people with speech, and they're like umbrellaing aphasia, but what they're doing is in some ways similar to this, but they're providing a free service where people can get access and just spend years working on restoring those parts of themselves. It's very strange and difficult work that is you know, the data here and the presentation here is from the clinician's perspective, but the patient doing it, you have to have a lot of support otherwise, which it's a huge issue. This isn't provided, and I don't even think people know about it. And so that making it happen in yourself is would be separate from PTSD, would be separate from other issues that I know.
Makes
we have
sense.
all these problems, and then they kind of get interconnected. And in my head, it's not like I'm like, oh, my default mode itches, you know, I need to deal with it. It's like you have to deal with it in this really weird way. And like cognition, working on cognition, it makes sense to me. I believe I experienced that working on it, helping everything else. But doing the work is hard. And I've visited other therapies where they don't focus on it in that same way. And I think it's, in my experience, a little bit not the best. So anyway,
kind of following up on that, do you see that most of your patients are not doing all these other types of therapy at the same time as doing your program, or are they doing other things at the same time?
Yes. It depends. It's a lot of effort. It's a big time commitment, right? If you have 3 cognitive training sessions a week for 90 minutes,
It's a lot.
it can be exhausting then to then do other therapies on the opposite days or the same days, you know, and try to work or go to school or, so it really just depends. There's such diversity in the brain injury population that everybody's story is a little bit different.
Thank you.
Can I ask a question? How do you get treated by the insurance industry?
So, so this program is offered in two different types of environments. Clinicians, speech and language pathologists, occupational therapists, school psychologists, neuropsychologists, if they offer it in their private practices, because we do license the program, or it is licensed, sorry.
Then it's covered.
It's covered for some
To some extent.
yes. But the freestanding learning RX centers those are self-pay.
Okay.
Okay. Just follow up on that. Like, what's the typical cost range? Like, what are we?
It's about the same as other therapies, $85 to $90 an hour.
Okay, well then we will
It's considered, but it actually isn't so bad.
Right.
You know?
With what have we learned? So in a TBI population with various causes, intensive cognitive training was associated with significant improvement in memory, attention, reasoning, processing speed, visual and auditory processing, and overall IQ score. And that in our research, all participants reported real life changes or transfer effects, and changes in the brain were measured after the completion of 60 hours of the cognitive training. And that's our contact information.